So we're going to be talking about investigations and diagnosis in cancer pain. So the aim of the talk is to identify the etiology of pain, including some of the pain syndromes, and also to look at using appropriate investigations and interventions to make certain of the symptomatic diagnosis and the management of pain in the palliative setting. So objectives will be to explore the importance of making the correct diagnosis, to review the different causes of pain, including acute pain, chronic pain and cancer pain, identify common pain syndromes in patients who have a cancer diagnosis, to determine the most appropriate investigations in terms of confirming the diagnosis, and some basic exploration of neuroanatomy and neurophysiology related to pain. So I guess the first question is a diagnosis important? And the answer is obviously yes, because treatment is going to be tailored to having a good, sound diagnosis. So we can do appropriate investigations for the patient. That may include bloods, but in particular medical imaging. And then if we need to refer the patient off for further specialist care, for example, radiotherapy, then that can be done. And so that appropriate advice is obtained and we can start treating the patient and sorting out their pain problems. So in the setting of a patient who has advanced cancer, the causes of pain are most likely going to be due to the tumour itself. However, there are other significant causes, including treatment-associated pains, pains due to general illness but not cancer, for example, osteoarthritis or rheumatoid disease, and pains that are unrelated to the cancer or its treatment. So tumour infiltration and spread can be many and varied. Bone metastases are a common problem in terms of causing pain. Soft tissue metastases are less common. Visceral disease is quite common, and one thinks of things like liver metastases, perhaps lung disease causing pain. And then finally we have nerve compression, which can be a significant cause of pain which is quite difficult to treat on occasions. Types of cancer pain can be broken down into somatic, visceral, neuropathic, and then sometimes mixed pains. And a good example of a mixed pain may be someone who's got spinal disease with both bony, which is somatic, and neuropathic nerve root disease. So if we look at firstly at bony secondaries, it's interesting that a patient may have multiple bony metastases, but only one or two will cause significant pain. And this is classically in the patient who has prostate cancer, where a bone scan can show multiple metastases, but there may only be one or two areas that are causing significant problems with pain. And that can be because of the site. For example, is it weight-bearing bone? So is the pain related to disease in the hip or the back? Just the extent of the disease? Is there cortical involvement? And particularly if the periosteum of the bone is involved, then pain may be a significant issue. Is the extent of the disease just causing the bone not to obviously fracture, but perhaps to bend? And this concept can sometimes be thought of as microfractures in the bone. And then there's the issue of involving other structures, particularly nerves, but sometimes muscle insertions and tendon insertions as well. Primary sites that are commonly associated with bony metastatic disease: prostate cancer I've already mentioned. Breast is very common. Myeloma is also common, and the vast majority of patients with myeloma will have bony disease, occasionally extraosseous disease. Lung cancer is very commonly associated with significant bony disease. And some of the less common tumours like kidney and melanoma can be associated with significant bony disease. And of course thyroid cancer is fairly uncommon in terms of its overall incidence, but once again can be an important cause to exclude in terms of bony metastatic disease. So just one syndrome that patients can commonly get is vertebral disease. And because it's a somatic pain, often the pain is fairly well localized, and with vertebral disease, obviously, it's felt by the patient, usually fairly close to the midline. If the patient has unilateral disease or pedicular disease, it may be associated with neuropathic pain on that particular side. And if there's epidural extension, then the patients may also get nerve root pain. So differential diagnosis in a patient with known cancer may include degenerative disease of the spine, including degenerative disc disease, osteoarthritis, and sometimes osteoporosis with the potential for crush fractures. Imaging the spine is obviously important in these patients who are complaining of pain, and plain x-rays are a very reasonable place to start. X-rays may show erosion of vertebral end plates. There may be vertebral collapse, but you must remember that this could be due to other causes. The x-rays may even show pedicle destruction. But if the x-rays are difficult to interpret or don't show anything significant, then you need to think about other investigations, including bone scan, which has a high pickup rate but doesn't actually give you much of the anatomy of what's involved with the disease. And if you go on from there, then obviously CT scan will show up the anatomy much better. And if you think there's neural disease or perhaps just infiltrative bone disease, then an MRI may be the investigation of choice in those patients. And so if you go through those investigations in a stepwise fashion, then you're likely to get the diagnosis. Just with some more localized syndromes, patients can get disease in the lower cervical, upper thoracic spine, and this may be a problem in patients with lung or breast cancer. And the patient typically gets pain in that area and with radiation to shoulders or arms. And if it's a T1 lesion in particular, there may be weakness of the hand muscles and triceps. If disease is involving the lumbosacral vertebrae, and that can occur with prostate as well as breast cancer, then pain once again will be midline with radiation to the sides. And it's interesting that pain may be worse with sitting or lying, and the patient may actually get relief when they're standing up. Sometimes there can be sensory loss as well with associated bladder and bowel dysfunction. If the sciatic nerve roots are actually involved, then the patient may complain of classical sciatic pain with radiation down the leg. Now, if the disease in the spine actually causes problems with relation to the spinal cord, then it's of the utmost importance that the patient is sorted out as quickly as possible. So spinal cord compression occurs in a small percentage of metastatic disease, but as I say, it's important to make the diagnosis. Most commonly it occurs in the thoracic spine and then in the lumbar spine, and it's unusual to see it in the cervical spine. Pain is usually made worse by coughing, sneezing or straining, or anything that causes increased intra-abdominal or intrathoracic pressure. And the onset can be extremely variable. The pain is usually present in about 90% of patients, and the neurology can come on over a fairly long period of time, or can come on over a matter of hours. And that's because the actual pathology is related not so much to pressure on the nerves, but on the vascular supply to the cord. So if the blood vessels are actually compressed by the tumour, then the cord will suffer significant ischemia, and this will be the cause of the paraplegia for the patient. So if one thinks of the diagnosis of spinal cord compression, then it needs to be treated as a medical emergency, and drug therapy needs to be instituted and imaging done as quickly as possible.